starting point for measuring the improvement that we hope to make over the next few years. So I'm going to run through it, and then there's time for a bit of debate and discussion. Actually, we've got a big discussion about this at the People Committee that follows this meeting this afternoon, so that's the board subcommittee that looks after all things people across University Hospital Sussex. So if I move to the first slide, and I'm just going to check again that this is working for you. Can you see now something that says participation summary? Yeah, great. You can see how older people like myself are a bit sort of nervous about whether this technology is always working. I once did a presentation where I think nobody heard me for the entire presentation because the internet had all gone down. So I'll keep looking for your reactions. So this is just a bit of a summary of the sort of scale of the survey. We had just over 8,000 people across our organisation. So if you think we're an organisation of around 20,000 staff, 16,000 substantive, about 4,000 bank staff. Our pure bank staff don't get to participate. I think there is something for us as a question mark in the future about, do we want to start once we get ourselves sorted, do we want to start instituting some sort of survey that we run amongst our bank staff about their experiences as well? But you can see we had a response rate of about 8,000 staff. So given we've got 16,000 staff, that was just under half. I was a little bit disappointed we didn't quite hit the 50%. That was a bit more than other organisations. So other organisations across the NHS in our group, of which there are 126, achieved a response rate of about 46%. But when we come to look at some of the detail, there are 126 organisations that are sort of classed in the same grouping as us, so that we can get a bit of a benchmark and a feel for how are our responses to the particular questions that make up the survey doing against other organisations. And we used what's called a mixed mode for the census. So most people were online, but we did have some areas of staff groups where it was felt that it was more likely that they would fill the questionnaire in if they had it in paper form. So we obtained paper copies for managers to be able to distribute. So that's the sort of background. And then just a little bit more background around the sort of survey structure. The national survey is conducted every year. There's a sort of standard set of questions that are used. This year, they have reorganised those questions. It's not a bad thing for us because I think there'll be some longevity to this, that the people promise that the NHS has developed. And as we're starting and it's a baseline for our new organisation, it's not a bad thing that the questions have been regrouped into these people promise themes, of which there are sort of 7. So this is national work that's been done around what are the things that people would want to see from their employment, described as these 7 people promises. So as you'd expect, they are about sort of compassion and inclusion, getting adequate recognition and reward, being heard, that health and safety is important, that we are learning organisations, people enjoy some flexibility in their work, team working takes place. And then there are 2 themes that are additional to this, and you'll have probably seen before in some of the reporting that we do. We report something called the engagement score, which is a measure that's made up of about 7 different questions that ask people about their sense of, partly inclusion, but do they work as a team, etc. And then generally just morale, and those have both been identified as themes. And most of these scores have a ranking of sort of between 0 and 10. That's the sort of way that the questions are asked in the service. So that's how the survey is structured, and then the reporting is done against has been done against those themes. And I think I might have shared this with you before, but this is the sort of overview of where our trust sort of performed against each of those themes. So if you take the very first one of those, we are compassionate and inclusive. You can see that the best scoring organisation scored 7.8 on that 10-point scale. And the worst performing organisation scored 6.7. The average was 7.2, and you can see that across our organisation we scored 7.1. So we are, as you can see, we are not as near our aspiration to be at the sort of green levels, the green lines, which are the best performing organisation. And probably the biggest gaps that we've got would be a little bit in sort of we're always learning. You can see there's quite a range there between the sort of worst performing organisation and the best performing organisation, almost a sort of full 2 points. We are somewhere in the just below average there, but quite a long way off the green. So a full point that would take us up to, you know, for a score from 5 to 6. I think the other ones you can see we're sort of a little bit behind, more behind average than we would like, or on things like morale at the moment and staff engagement. So the 2 at the end, and we'll probably get to understand if I take when we go through some of the questions, you can sort of see what might be driving some of those things. But that sort of gives you a bit of a sense of the overview. So clearly, plenty of scope for making improvement for across the organisation. One of the things we can do a little bit later is just look at the sort of differences between sort of what were legacy Western and legacy Brighton Sussex University hospitals, because there are some differences which I think point to some of the things that we might, you know, where we can make improvement quite rapidly as well. So that's the sort of overview. So disappointing in a way, but you know, it's very clear where we are. I think it has been a very tough COVID period for the organisation, and of course we've had all of the uncertainty of a merger that other organisations haven't been going through at the same sort of time. If you look at the sort of where have we done best out of all of those people promise areas, out of the 7, you can see, and this is probably a good thing in my book, you know, one of the things that, you know, we are is a values driven organization, and one of the things that or the thing that has come out top is that people do feel that their colleagues are compassionate and inclusive. So we're doing that. We've got a voice that counts. We are a team. We're working flexibly. So some of those are good things that are at the top of our scores and responses. These are then broken down into a few sort of smaller areas. And you can sort of see there's 15 of these, and you can see, you know, what's pulled us down on things like we're always learning is that, you know, people aren't potentially getting the appraisals. We've seen that sort of, you know, process drop off, you know, during the pandemic, perhaps not enough time and rigor. You can see, you know, number 4, it's at ranked 14, you know, health and safety, you know, people feeling that there's enough sort of support for their well-being, the health and safety climate in the organisation, work-life balance, all of those things that we've seen come under pressure over the last 2 years. But that just gives you a sort of sense. I think what's more interesting is the next few slides around the sort of what the individual questions were and the results, and where we differ either from the national picture a little bit, or where we've got that variation between the East and West legacy organisation parts of the organisation. I've tried to highlight a few by circling the scores here, just to draw my attention to sort of point them out to you. So, and I'm just going to go through these with a little bit of some of this is hypothesis, because we're still testing this with staff, and one of the things we will use this we're using the staff survey to do is to go and engage with people using it at a divisional level as well, to sort of talk to staff about their experiences. So you can see 21C is the question I would recommend UH Sussex to friends and family as a place to work. We've fallen back overall 13 percentage points there, and that's higher than what's happened nationally. So nationally, this score has fallen. So the NHS isn't being recommended as a place to work as much as it used to be by staff. Nationally, that score's fallen by 9%. We've fallen by 13%, and you can see there's a degree of variance between the two sort of former organisations in how much that's fallen. So it's fallen a bit more at Legacy East than it has at Legacy West, but actually not that much more. So what that tells me is that both organisations have experienced a sort of downturn in staff experience, which I suspect is pandemic driven. It's been a bit worse than has been experienced perhaps in other NHS organisations we're benchmarked against. We can probably hypothesize it. I think what's interesting is if you then correlate that score recommendation as a place to work. So it's been reasonably even, the fall in recommendation as a place to work, but with a little bit worse at Eastern. If you look at the would we recommend our organisation as a place for our family members to receive treatment, nationally that score's fallen by 7%. For us, it's fallen by 10% overall, but we've got a greater degree of variation between what's happened east and west there. So it's particularly on the east, 14% less staff, this year would have recommended the organisation the place to receive treatment. It's fallen much less, it's fallen, but much more in line with the national average over on the western side. So I think what this points to is there's quite a lot of our pressure has been in the Brighton side of the organisation. If you look at the next score as well there, whether the care of patients is the organisation's top priority. Again, that's fallen nationally. As people have been sort of coping with the pandemic, we've fallen a bit more, but again, sort of the western side much more in line with the national average a little bit. It's over in the east that people have felt that's, and I think it's some of that I will say is I do think the sort of COVID experience at Brighton has been quite tough, and we know it already had challenges with the size of the emergency department that we've got and some of the pressure that creates in the way that staff are able to cope with dealing with people. If I take the next sort of bank of questions that sort of look then a little bit, I look forward to going to work, I'm enthusiastic, my job, time passes quickly. You'll see that in a couple of those, we've fallen. Again, we've fallen. Enthusiasm is something we've fallen much more markedly than other organisations, and I think that might be a little bit attributed to the uncertainty that we've been going through with sort of leadership and merger and the changes and people not knowing what their roles will be. Getting that security of what our structure will be for the future. Again, it's hypothesis. We need to test some of that with our staff. And then the other interesting one that I pulled up on this was, actually we've sort of seen nationally, again, question 3F at the bottom there. Nationally, we've seen a decline in 2% of people sort of feeling as though they can make improvements happen in their areas of work. And we've fallen again further than the national average on that, so 4% over in Western, but 9% over at Brighton. So there is something a little bit about people perhaps not feeling, and again, is it a structural thing? Is it a sheer sort of it's too difficult to make changes? Have we not had the structures embedded in there? And this contrasts, of course, with only a few years ago when actually Brighton had shown really major improvement in the staff survey in some of these questions. So I think in a way there's a little bit of some of those processes and those ways of engaging staff, some of the things that were there, and I think there's some justification for this hypothesis when we get right to the end of the presentation, haven't embedded enough, and in a way COVID and some of the disruption we've seen has interfered with those. I'm just going to take us through sort of the next slide, and again, you can see there are a few more rings around the Legacy East sort of questions, which is where they do seem to have, it seems that the responses have sort of fallen there much more. So, staff involvement's really important, staff feeling as though they're party to changes, etc., that get made. And again, that's fallen nationally, but not that much actually compared to some of the other things that have fallen back nationally, only by 1%. But for us, it's 2% at Legacy West, but 6% in the East. So again, what is it that's caused us not to have staff who are quite as sort of being involved in how things get decided for them? Now, again, that might be because they're things to do with merger and they, the structures aren't there, and they haven't had a management team, or the management team that's there engaged with is temporary because we're working through new structures, which the good news is we will get to the end of by July. Just picked out that relationships at work are strained. Again, nationally, that's fallen a bit. People under more pressure, fallen 3%. Again, Legacy West not far off at 5%, but a little bit more. But actually, again, at the Brighton side of things, the former BSUH by 8%. And similarly, if you look at the questions highlighted in sort of brown there, about people, whether they have negative thoughts, looking for a new job, leaving the organisation. Again, it's fallen back nationally. Again, sort of probably the West not far off what's happened against the national average, but over in the East, at that it is a much greater sort of sense of dissatisfaction, or people expressing those comments. But then the surveys can be contradictory around some of the things that you think might be driving these things. One of the things that I noticed that actually, question 3I, have we got enough staff in our organisation? Actually, both East and West both feel very similarly about that. So 14% less people each year on both East and West. We've seen a decline of 14% in answer to the question that there are enough staff in our organisation to do the job properly. That contrasts with the national fall of 11%. So there's clearly a national narrative, that there aren't enough staff in the NHS that's sort of partly driven that. But I was a bit surprised to see Legacy West perhaps being quite so a dramatic a fall in that, given that some of the other questions that are asked, that hasn't been quite that negative. But again, it all points to the stretch that our organisations have been under. So that's what the picture is, sort of East and West. Do you want me to pause there and just take any questions on that, Lynn, or do you want me to sort of get through the presentation? Because the next thing would be to just take us through a bit of a divisional oversight, some local questions that we've asked, which sort of I think sort of sets help a full context. And but I'm happy to be in your hands about whether people want to just ask any immediate questions or.
I actually think it would be quite useful for us to see the next part that will bring in some of that context. Does everybody agree? And then we'll come out for
that's
questions.
fine. We've got quite a bit of time. I'm taking my time on this, and obviously we can send these slides round to you afterwards. They're not confidential information or anything like that. So if I just tell you, so if I go back again to those sort of 7 themes, this is a sort of heat map, if you like, comparing all of our current divisions against, how they've scored. So you can see, so for those of you that don't know, 279 are all former Western Sussex Hospitals divisions. 379, that's the organisation codes that we operate under, is former BSUH. So again, reflecting that data that you've just seen, you can see that all of the BSUH divisions are scoring lower than the Western divisions, and you can see that if you look at this as a ranking, unfortunately it's our surgery division at the over at Brighton that's coming off the worst here, and they're close to and very similar to, actually, in a way, one of the the brown line is the worst trust performance in our comparator group. So what that tells us is that for our staff in surgery, their experience is as bad as it is in the worst trust in the UK. Look, that's only for one of our divisions, and it's not where we want to be, but that's how bad it is in one of our organisations. But we've got core services, corporate divisions, division of medicine over in West. We've got some other areas that are doing, they're not doing the best, but they're not doing badly. But this heat map sort of shows you, and it shows you where, because even some of the areas that are not performing well in one or two things, so estates and facilities, actually they are doing better, around health and safety perhaps, and working flexibly and things like that. So there are green shoots. What we are going to do is a recut of this data, so that every one of our new divisions being created under the clinical operating model, which I know Andy's briefed you about before, so we're going to have the new 8 divisions, they will get a fresh set of data that shows them where they sit in this sort of chart, and also therefore helps inform what's the sort of things that they might need to focus on with their staff as part of a new leadership team and a new division being established. And I think so that'll be really interesting. So for maternity, obviously, because children's services will run across the organisation, there'll be a bit of a new cut of this data. We will still want to try and see some of the split by site or split by hospital, but that's something that we're that's work in progress, because there's a data cut that's needed to do that. So how's all of this moved? I think you can tell by looking at the chart that unfortunately what this tells us is that 48% of the 48 of the questions, 76% of them have shown a significant decline since last year. 24% no movement, and we've not really significantly improved on any. And by significant improvement, that's about, is there a statistically significant change in the data? So it's not, it's not great. It's not great news. but I think it is a good baseline for us to be able to sort of, and I think there's quite a lot we can do quite quickly to make improvement and attack some of this. Just going to dwell a little bit on the experience of our Black and minority ethnic staff. So there's a set of questions that are asked in the staff survey that inform our workforce race equality standards scoring. And what they're trying to do is look at, as you can see, indicator 5, the percentage of staff experience harassment, bullying or abuse from patients or relatives, and is there a difference in the experience between our Black and minority ethnic staff and our white staff. And you can see the scores there. So for BSUH, last year, 31% of our white staff sort of say that they experienced abuse from patient staff, 37% of our Black and minority ethnic staff. And that's more for both sets of staff actually than the national average in 2021. So nationally, 28% of BAME staff experienced it, 37 in our organisation. White staff, the national average 25, we had 31%. So we have got a violence and aggression sort of working group that is up and running that will be using this data to sort of help inform, some of the interventions that we make to try and do that. The better news is we're not that dissimilar from other organisations in terms of BAME staff experiencing any abuse from their colleagues, from staff. So again, we're very much in line with the national average on that, which is 29%. White staff slightly more than the national average at 2%, but actually our BAME staff, it's the same experience as others. And actually, it's again still slightly higher than our than white colleagues. So we do, we need to take action on that. But the position is that's much more in line with the national average. It seems that it's with our patient community that we seem to have had sort of more of a poor experience than in other organisations. And then in terms of career opportunities, I think this is a really interesting, and I apologise for not ringing the numbers here because they stood out to me. So if you look at the white staff and their experience of whether the organisation provides equal opportunities for career progression or promotion, you'll see that we've fallen down to 55% from it being 86, 89% down to 55 against a national average of 88%. But even that, national average of 59%. So there's been a substantial fall in people's sense of fairness about how people get jobs. And I think that's probably a result of, so it's something that's been reflected nationally. It's probably a result of temporary changes being made, people being temporarily moved to do things as we do things to respond to the COVID pandemic. On top of that, of course, we've had the merger and therefore need to put people temporarily in charge of things. And of course, that whole process of doing. So I was surprised actually nationally that had changed quite so much because I was expecting it to have changed for us, but not quite as much that as in a way as nationally. You'll see again, for Black and minority ethnic staff, it has crashed. From sort of 82% down to 40, around 70 and 80% down to 45, 46%. But again, that's in line with the national average. So again, there's been a very big change in people's sense of, and again, this must be down to what's changed since the year before. It's COVID. It's the way that we've been recruiting people and, putting a lot of people into temporary roles, or people have had temporary acting ups and things like that to manage the sort of COVID pandemic. And I think there is a sense of, how do we do that more fairly in future? And if there's ever a repeat of this sort of thing, how do we make sure people are getting fair opportunity about acting up opportunities and things like that? And then the other one, again, where we're not particularly out of line with things nationally, is the percentage of staff experience of discrimination at work from their manager or team leader. So similar set of questions for WIDES. Again, I'm not going to dwell on these because actually these are very much more similar to the sort of national experience. There's very less differential, if you like, between us and other organisations, and not that much differential in a way. There's a bit, but not that much differential between former BSUH and UH Sussex. But I thought what was very interesting, and we deliberately put these in, was some local questions that we put in. And these were really designed to see sort of, what's the way the organization operates, and how embedded is patient first, because that's our particular way that we think things are going to get changed over time. And it really struck me when I read these, when you go back to some of those questions about the sense, and particularly at the Brighton side of things, of people not feeling that they can make improvement or that they're not engaged. One of the things that's really different between the two sides of the organization is the frequency with which teams get together, either to have a safety huddle or a team meeting. And I've ringed these results here. So, so over on the western side of our organization, people, 60% of our staff are saying they have some sort of daily meeting with their teams. It's half that over in the former eastern side of our organization. And even if you look at having a weekly meeting, there's clearly less on the legacy WSHT side because people are meeting daily. So a weekly meeting becomes a sort of less free. But actually, it's only 28%. You add those two numbers together. We've got a significantly less getting together happening over on that sort of eastern side. And that's one thing that I can notice is a practical difference in the way that our two trusts, or the two bits of our trust, operate. If you then look at what gets talked about in those meetings, actually there's a bit of difference between the two sides of the organization, but not that much. They are talking about, when they do get together, they do talk about patient first targets or objectives and the things they're trying to achieve. They do talk about progress against team objectives. There's a little bit more maybe on the West, but it's so the thing that's not happening is the actual meetings rather than what goes on in those meetings. That's where the difference resides. And then the final slide, and it's not that we've got differences either in some of the quantity of training that people have had in patient first. So actually, again, across both sides of the organization, it's about half our staff have had some training. So the difference is the way that's being applied and the way that things, and the rhythm of how the organization runs a little bit, which I know we've sort of started addressing through some of the activities that Andy's introduced around sort of revitalizing patient first across the organization, reintroducing some of the standard things. So I think it all points a bit to whether it's not the distraction of COVID, because COVID's been a very, very serious issue to sort of deal with. But then that coupled with merger, I think some of those sort of basic functions of actually a well-functioning team needs to meet frequently enough to be able to talk about what it's supposed to be doing and delivering, have just sort of dropped off a bit, possibly because we've had, lots of movements of leadership and things like that as well. So that's that's one of those things. And then finally, we asked some local questions about senior leaders. And again, that's a little bit open to interpretation. But again, what I would point to here is that, again, there's not that much difference between the two sides of the organization. So senior leaders, take time to interact. Well, actually at BSUH, it was 21%, 26% at Western. We need to raise that, but actually there's not a difference between the different sides of the organization. Similar, are we aware of, our senior leaders aware of frontline challenges? It's not good enough because it's 21 and 26%, but it's not that different between the two sides of the organization. The good thing I sort of thought was really positive was that, actually, local questions 7A and 7B, people are recognise that actually colleagues and indeed managers do seek to live by the trust values. So again, coming back to that value base, we've got, the people we've got are well motivated. A lot of what we need to change is how we organise ourselves, and which comes in a way to the sort of expectations we have of our leadership teams, the rhythm with which we expect them to meet with their teams, the sort of structured processes we expect them to use in those meetings to make sure that issues get aired and addressed. I think means that actually those are not difficult things to start to get put back in place if they've things that have been lacking. And with Patient First, we've got a bit of a methodology to do that. And with the introduction of the new clinical operating model and new clinical team leadership, if you like, across our divisions, I think there's a real opportunity to sort of quite quickly address some of those things. So I'll just briefly talk about next steps, Lynn, and then open it up for a bit of discussion and see if people share some of my observations. I mean, one of the things that we've done is we've got these breakdowns now that each division has, so they can have a much more detailed look at how their own, if you remember that chart I had which showed the scores by theme for each division, they can now have a look at that. They can have a look at it by what their staff group in their division. So is there a difference between what the medical staff are saying and what the nurses are saying in a division? So that work is undergone now. We're also, as I say, going to get a new version of that sort of puts that data by the new clinical operating model, so that the new teams can have that discussion sort of informed, with data that covers the whole of what that new structure looks like. And we've got a discussion at our people committee, which is coming up later this afternoon. And of course, one of the things that we're doing, as well as this is the start of the year, is a review of what are our breakthrough objectives for this year? Do we need to change any of them, tweak any of them? The results are all, so the results that we've had on things like health and well-being are feeding into our review of our health and well-being strategy that's underway, that we'll be talking about at the people committee this afternoon. So, it's data that's cut at one point in time, and remember that the survey was between September and November 2021. I think that was, if we remember back, that was a particularly tough time for the organisation, and I do think but there's an awful lot we can take out of this. I think one of the things that we're using it for really is as a way of also engaging staff, so being able to take the results out to people, talk about them, which we're then trying to triangulate with what we're hearing through the listening events that we've been running with staff across the organisation, particularly in surgery and maternity, and quite often, more often than not, the data will chime, and we know the reasons for some of these things. I think what we now need to do is work with those new leadership teams as they're appointed around what it is we're doing further to address these. But I hope that's a helpful overview. If you think it would be helpful to sort of see the data by, professional group and things like that, we've got some of those data packs, but I didn't want to overwhelm you with information. I thought it was better to just have a sort of discursive discussion, and be interesting to see what whether you have any different feelings, or from some of your walkabouts as well, and engagement through some of our peer review processes and things like that, whether that chimes or whether there are different things that you've heard. Is that helpful, Lynn?
David, that was so useful. Thank you. I really appreciate you taking the time to go through it. I've got loads of questions because it's such a priority, isn't it, for the trust? But what I thought I'd do is open up the floor to everybody else. And then if they don't ask the same questions, I shall come in at the end. Thank you. Paul. Paul, you're on mute.
Thank you, Lynn, and thank you, David. That's really echo what Lynn said. Very, very comprehensive. I suppose my feeling is that I'm very much glass half full rather than empty on this. Why? Well, first of all, I wonder when we're looking at green lines, best performing. I have to wonder what the definition or the benchmark for that is in terms of comparable trusts, organizations, in terms of size and demographics and specialties, given that, we are the major trauma centre for the Southeast, 7 hospitals, merger, as you said, and COVID. And and I would also, think in terms of the 51% that did not answer, what's the reason for that? Is it because they didn't have sufficiently strongly held views on the subject, or, I'm okay with it, or, we're better than fine, or we're fine, or we're average. It's just, I'm not the 51% who didn't feel moved to actually jump in. As far as BSUH is concerned, yes, that's been a huge issue. We also, I think, need to realise or remember what an amazing thing it was coming out of special measures, and that wasn't all that long ago. It just shows that huge turnarounds can happen when really you're not expecting quite as much to happen in such a short time. the margins that you've gone through question by question really are very, very narrow, it seems to me. We also know at Brighton, BSUH, so the focus right now, that the heads up that we've had for some months on maternity and surgical. So, I mean, I really feel that that's going to go up and up and better and better. It is a bit depressing for people in terms of everything and the stress, as you say. So perhaps they're feeling a little bit more on the sharp end of things, and as things settle down a bit, as we hope, that will change. I think that's yeah, I think that's it. Thank you.
Thank you, Paul. Fran? You're on mute, Fran.
Thank you. Yeah, following on a little bit at what Paul said, I think there is an issue about why so many people don't respond, because it is difficult to speculate whether they think, oh, I can't be bothered, nobody does anything anyway, or whether they think, well, it's perfectly all right, or something else. So I'm just wondering whether or not, both in terms of that and maybe to unpick a little bit more of the quality of stuff, you know, some of the things that have come out that where we are behind the curve, whether there's been any sort of either random or spot interviews with people to try and get some more detail, because this just raises questions, doesn't it, rather than gives you all the answers. So just a sort of a question there. Then I suppose related to that, your observation about the bank staff aren't included, and I think that's pretty serious myself. I don't know what the percentage of staff are bank staff, but it's quite high, and in some places higher than others. And often people who are on the bank move around a lot, and they have observations that are different to the staff that are normally in the hospital, and can sometimes give, you know, pretty comparative views. So again, is there any way of doing some work to pick up what they're saying, because they could be very good, give very good, you know, sort of an outsider view as well as an insider view. And the other thing is, more generally, I suppose it's to do with the NHS generally, because on the one hand the expectations are high, and the second it's constantly getting a kicking for not delivering on this, that and the other, isn't it, for whatever reason. And I just wonder whether or not there's any benchmarking that is similar in other organisations, particularly those ones who've been under the cosh in COVID. And probably nothing has been under the cosh in the same way as the NHS, but maybe some social care and educational places, to see whether or not, you know, just generally about whether or not how we feature in relation to others. And I know that's a bigger picture thing, but it just feels to me like it's a bit like the glass half empty, half full thing that Paul, you know, sort of think, you know, it's trying to sort of like not, you know, be totally negative. So those were more general stuff. It does feel as if appraisals keeps coming up all the time, and I do think that that if some, I don't know where we are on that, but if a handle could be got on that, I mean, one, it gives you the detailed feedback maybe that I mentioned earlier on. Secondly, it accredits the work of people. It gives them a space to be able to say what they would like in their career, which is obviously low down, you know, etc. All of those things. And it just feels if you're going to try and do something that, you know, might hit a few of the buttons, you know, really prioritizing those appraisals for people. I know it's difficult. People are actually working flat out, if you like, on the day job, and to try and find time, some quality time, you know, to have a bit of space for yourself is really difficult. But it does feel like there must be some way of actually doing that if we're going to turn around some of the issues. I could say a lot of other things. I've probably said too much, but the one other thing that I think stands out is about the abuse and bullying and all the rest of it, whether it's from patients and family members or other staff. And it just feels like that's really, really high. And, you know, to go into work and be, you know, sort of work your guts out in a very difficult situation, never know what you're going to get. never know whether you got a full complement of staff on, etc., etc. What's coming through the door, and and what government edict's going to come down, that day or something. I think then to be in a sort of a very frightening, bullying, abusive, negative environment. So again, that's something that I think maybe the appraisals might help to unpick that a little bit, but other things as well. You said there's a group, I think, that's looking at that. Would be interested in a little bit more, knowing a little bit more, not now, about how that's what's happening there.
Thank you, Francis. I mean, I take Paul's glass half full sort of approach to this myself. Actually, I think if these are the results that we get, and we've still got people scoring highly on the values and things like that, with everything that's been thrown at them. Actually, I think I think there are pointers in here to things that can make it better. I think there are some unique challenges to our organisation that are a bit over and above what other organisations were experiencing. And I've mentioned there's the county space issue. We know we've got resolution of, or partial resolution of, some of that with the 3Ts opening next year. We've still got a space issue to resolve for ED, but that will help in some way towards that. But I think that's a different driver that other people don't have. So if I were to look at a well-performing hospital like Milton Keynes, they've got a very adequately sized ED, and they aren't a specialist trauma centre like, as Paul identifies, like we are. I think you're right about some of those basics and appraisals. Actually, just on that, we have relaunched our appraisals with a new documentation, very much building on the welfare approach that was taken before. So it's very much about your development, your welfare, and your career as well, as well as sort of the performance delivery. So that material's out, and I know we have, as an exec team, have talked very much about how do we make sure that some of these basics are coming back in for staff, and we have to make time for that to happen.
Thank you, Fran. Lindy.
I just wanted to quickly pick up, actually, Fran has mentioned my topic, just quickly about bank staff. I can speak from experience, and it really is a situation where you begin to feel a second-class system, a second-class member of staff. There's many things that, nothing more surprised me that I wasn't allowed to do the staff survey. I wasn't allowed to any longer have any access to the MAP system, which is your duty rostering. I was only allowed to access that as an employee online. And I think most of all, there was this, I was told that, I wouldn't be paid the same grade. And there was because we were all midwives and there was quite a few of us that retired at the same time, we actually had to raise this as quite an issue in order to the fact that we could still do the same job. But they wanted, for some reason, just because you had changed your sort of status system from stantive job to bank job, you no longer were, I lost for words really, up to the standard of doing the same job and therefore required the same pay. So there's an awful lot that needs to be looked into in the bank situation, because so many people who are on the bank were actually employees, retired, and decided they give some time to the bank.
Thank you, Lindy.
That's me.
No, first hand. David, did you want to come back on anything there?
No, I think there is something for us to look at that. We are trying to do one of the pieces of work we've been engaged in is a big piece of work around sort of the harmonisation of how we operate the banks. You'll know we've been putting in different rostering systems, or a single rostering system, so that we've got a much better overview of what's going on. I do think there's a very valid point there about actually what more engagement do we do with our bank workers? How do we hear their voice? We are appointing a clinical lead. So to sort of take a bit of ownership around the sort of bank, particularly the bank nursing workforce. So I think there's probably more for us to do there. So it's really helpful to have that feedback, Lindy. And I definitely, it's on my list of actually, well, do we need to look at, even if it's not the NHS staff surveys, there's something that we do to try and test the mood and sort of, include those staff more in that. In that discussion about what works and what might make things better, and where do we sort of see responsibility for that sitting.
Thank you. Doug.
Yes, on the question of abuse and bullying, we have numbers that come out on the staff survey, but what about during the year? Are these being reported, or is it something that surprises you only when the survey comes out?
No, so we would expect these incidents to sort of get logged on Datix, so which is our incident reporting system. I think there is a legitimate question to ask, though, Doug, about do people do that or do they not do that because they feel as though it's not, nothing will be done about it. So as I mentioned, one of the things we've been trying to do is to very much, build up our listening to staff. So one of the things that my teams are looking at the moment is trying to map all of the various forums and data that we have that in a way gives us a bit of an impression around sort of what's happening for staff. So our staff engagement, either whether that's, evidence and what we hear from sort of listening events, whether it's data evidence from what we're getting through Datix reports, whether it's feedback from surveys, whether it's feedback from visits or inspections that we have. How do we gather all of that data in a more systemic way to be able to inform what we do? I think that would help us, because it certainly did come up, and we know it's been driven partly by the issue of mask wearing. So a lot of the public, not particularly tolerant of feeling that they need to wear masks in hospitals. And of course, who's at the front line trying to enforce that? It's our staff members. Or enforcing limitations on visiting and things like that. There's a lot we've asked staff to do where they're having to manage, public expectations. And I do think there is work we can do in that area. So part of it is setting the expectations of the public before they come. We do run a bit of a risk in this area because there is a slight worry that there might be a bit of a mismatch between, in a way, our ability to deliver service and the timeliness with which people want to be seen and the quality with which people would want to receive services, given the pressures that we're under, mean that patients' expectations may not always be met. So is there anything we can do about, managing people's waiting times to make sure that they feel as though they're engaged and that we've helped them with having to wait for an operation rather than they don't hear anything from us and then they just suddenly get a letter when we are able to do their operation? All of those sorts of things are things that can help manage that relationship between our staff and the public in a way that those tensions aren't fueled by, if you like, us failing to meet what if there's a mismatch between their expectations and what we're able to deliver. So I think that's going to be a really interesting, and quite difficult thing for the NHS over the next sort of 12 months as we try and tackle the backlog.
I still think we should have zero tolerance, though.
Oh, of abuse, yes. No, yeah.
It's difficult to police, though.
Yeah, although we've got plenty, I've seen security guards escorting people off the site. There is a zero tolerance across the trust, isn't there, David? And it's just tough when staff...
There is, but I do think there is something as well, though, about sort of trying to get patients and their partners and things like that to arrive calmly, because of course, if we've added to their stress by not being very clear in the letter about expectations or that it'll be difficult to park, or we sometimes allow people to get here more stressed than they need to be. And if we can just lower that bit, it might be the thing that's we've removed the straw that might break the camel's back for a member of the public sometimes, I think. Look, I just want to say, Lynn, I'm going to have to go in about 5 minutes because Alan wants to see me before the people committee. Right. So just to put a time check on how long I can stay.
Pauline?
It's okay. It's just very briefly that pre-COVID, we did have a group that was reducing abusive behaviour, which was both staff on staff and patients. So is that group finished now? I was on it, but I've not heard anything more since COVID.
We're just restarting one, Pauline, so it might be that we need to bring you back onto that group. So okay. We're having a discussion about it at the people committee just after this meeting.
Oh, well, there you go. Thank you.
Right, so I've got loads of questions, David, and if need be, I'll send you a note. But I wasn't surprised by the survey just with the merger, although lots of hospitals merged, didn't they, through the pandemic and with just the pressure. But I see it as a really fabulous opportunity to demonstrate to staff that we do listen and we do improve and we do want to make it better better. So I think it'll be quite a good starting point to reinvigorate culture across the trust. Are we doing enough to ensure we have capacity for people to actually do their jobs properly?
No, I think that's a genuine issue of where things have been, it comes back to some of those basics and, why have some things sort of slipped off the radar. I think it's because of pressures. I think there is something about, so it's a bit like our redesign of appraisal. We've tried to make it in a way easier to guide people through it and a bit more flexible, but not without losing any of that. I mean, somebody made the point in the chat about, it still needs to be a good quality experience. And for people and actually genuinely add value. And we did a lot of road testing of it. It's why we've been a bit later launching it than we would have otherwise been. But we've done a lot of road testing it, worked with staff side on it, road tested it in Mark Sargent's departments, and they tweaked it as a result. So again, I think this is the sort of, we can tell that story now of how we developed something which genuinely we've tested and people have found useful. And actually we need to sort of continue to revisit how we use that. But I think creating the time and the space, I think one of the things we've been talking about as an exec team is how when we create the new divisions and the leadership teams there, we have put investment into new roles. We've expanded the sort of managerial capacity. We need to set some clear expectations of what we think people will be focusing on, and I think some of it's sometimes not necessarily been about there being lack of capacity to do it, but also as perhaps not always having had the clarity about who is expected to see that things happen. So I think we've got an opportunity, glass half full, to get those things right, to set some expectations early for those new leadership teams, and also as a leadership team ourselves as execs to make sure that we're following those principles and doing those things for our staff, because we need to cascade this down the organisation.
Yeah, no, agreed. Obviously, there was a conversation about why staff don't respond, but doing listening events sounds like, an encouraging thing to do. But are we actually doing that across every division, such as facilities and estates? I'd love to see what their input was, how many answered, because a lot of them don't have NHS emails. They're very short-staffed. And somebody, as an example, yesterday was told she was going to have her appraisal, and she'd already had hers in January. So I think there might be a mismatch as well in the data, in so much as it's not being collated as to who's had appraisal. So there might be a glitch in the system, which is skewing some of the numbers.
Yeah. So just on that, Lynn. We are trying to, what we're doing is, on the basis of the experience with maternity and surgery, is work up a pack, and if you like, a standard way of doing sort of staff engagement, staff listening events. That one of the expectations we might set of our new divisional leadership teams is that they are doing those with a degree of frequency which may not be exactly the same, but there's probably a minimum and there's probably a maximum that we're sort of expecting people to deliver. So that's the approach that we've been taking, and by doing that, it's a bit of giving people the tools and setting the expectation, and then also providing them the sort of feedback and the way that information that we might be collating from other sources, so they've got something to go on. And I think it's a bit like see one, do one, teach one as well. That actually sometimes our people are a bit afraid of running that sort of open forum. So have they got the skills and the confidence to be able to run it, to manage it in a way that's respectful? And in a way, we've been trying to role model that. So I led some of the first maternity ones. Maggie, and I think in a way Emma Chambers will take over doing some of those for maternity in the future. So it's all been a little bit around sort of, we're learning how to do this. It's not that we didn't know how to do it, but this is one of those days where Teams has provided a bit of a new opportunity to do things differently. So I think in some ways we want that softer empirical sort of exposure and listening to people and being seen to listen to people, as well as the sort of data side of it of sending surveys. And we're just reviewing, is there any way we can complement, what are our tools for getting feedback back? Is it SurveyMonkey? Can we use something in the roster system to do that? How do we do it for bank staff? Are all questions we need to examine and come up with our sort of standard methodology and expectations around what we will do and when we will do it.
David, thank you. I can see that you need to be gone. I've got a couple of questions. I might send you a little note.
Please do. And then and all of you, if anything else that follows up, and I'm more than happy to come back and talk again about, as you say, our staff are our most important thing. I'm always very keen to engage with the governors about that.
Well, that's how I'd like to wrap up. If there's anything that as governors we can do to support some of these processes, please engage us.
Well, and I think sometimes, when you're out and about, if you're doing those, you can be really important in helping us set some of those expectations as well. So if we're clear with you, you can be the sort of other eyes that are asking when you're going and doing walkabouts and things like that. If you're engaged in those peer reviews and things like that, well, how do you know what staff, how would you know if your staff were happy or not is a good question to ask our leaders, isn't it?
That's a brilliant question. Really appreciate your time. I think that.
Thank you. Thanks very much, everybody. Bye-bye.
Guys.
Bye. Thank you.